Hi guys, welcome back to the channel after the weekend. So we have started with squamous cell carcinoma of pharyngeal tongue. We have dealt with the clinical presentation, differential diagnosis, diagnostic workup, and histopathology. So today we'll be dealing with treatment and prognosis. Okay, let's start. Treatment. Cases in which the primary tumor is unassociated with regional lymph node metastasis are treated mostly with bilateral high dose of radiotherapy. तो जिसमें lymph node metastasis are unassociated with the primary tumor, they are treated mostly with bilateral high dose of radiotherapy of the primary tumor and the neck in the range of 6,400 centigrade to 7,200 centigrade. If the neck mass is large, surgery in the form of complete radical neck dissection is often combined with post-op radiotherapy in the same dose range. Okay, so dose range same रहेगा, that is 6,400 centigrade to 7,200 centigrade. Now prognosis and follow-up. The general prognosis is poor. Considering all TNM classes, the overall adjusted 5-year survival rate is almost 15 to 25%. Follow-up consisting of nasopharyngoscopy or indirect laryngoscopy in addition to clinical examination is carried out, which is every 4 months for 2 years, first 2 years, and every 6 months thereafter, and an annual chest radiograph is recommended. Okay, that was all about squamous cell carcinoma of pharyngeal tongue. Now we'll be starting with squamous cell carcinoma of floor of mouth. Okay, first, clinical presentation. 15% to 20% of intraoral carcinoma. So after tongue, the most common intraoral carcinoma is floor of mouth. Present as a red-white patch or an ulcer. Induration is present if the lesion has infiltrated into the underlying tissue. Many of the lesions are present with palpable regional neck metastasis, which is often bilateral because of the thinness of the floor of the tissues, and the abundant crossover lymphatics in this region. So there is the abundant crossover of lymphatics. So bilateral metastasis is more commonly seen. Now coming to the differential diagnosis, narrower differential diagnosis, ज़्यादा differential diagnosis होता नहीं है floor of mouth squamous cell carcinoma का. The main one is traumatic ulcer and syphilis cancers, or the verrucous carcinoma if it is a non-ulcerated lesion. Diagnostic workup. It requires clinical, oral and head neck examination. So clinical, oral and head neck examination, including a mirror or fiber optic examination of the laryngopharynx, followed by TNM staging and an incisional biopsy. So mostly diagnostic workup are same, like oral squamous cell carcinoma of oral tongue. Now coming to histopathology, frequently evolve from a dysplastic epithelium. Many cases develop around the orifice of Wathen's duct. So it is recommended that the dysplastic process will often extend into the ductal epithelium. Now coming to the treatment plan. Surgery is preferred because of the high incidence of severe osteoradionecrosis when radiation of the floor of mouth exceeds 6,800 centigrade. तो treatment में in floor of mouth surgery is preferred because there is a high incidence of severe osteoradionecrosis. Because the adult mandible becomes more perfused with age from the lingual periosteal vascular plexus than from the inferior alveolar system, radiotherapy to the floor of mouth affects this critical blood supply. creating some of the refractory cases of mandibular osteoradionecrosis. क्योंकि ज़्यादा परफ्यूज हो जाते हैं with age, तो ये जो जो इनके critical blood supply है will lead to the refractory cases of mandibular osteoradionecrosis. Okay, that's all for today. We'll be continuing this in the next class. Till then, like, share, subscribe and comment.